Everyone. Good morning, Bone and Joint team. I'm here with Julie Dickinson, who is the Systems Director of Legal of basically risk management. And she is here, and thank you again, Julie, being here, because we wanted to talk about one of our falls. And every so often we have a fall where a patient says, no, 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 I don't want you in the bathroom. So the PCT or nurse or whomever will be outside waiting for the patient. Now, there's two things Julie will address: all safety versus privacy. And then Julie will address basically the ins and outs and how we get around that and how we can mitigate all before the patient could say, no, 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 no matter what you say. So Julie, I'm passing you the baton, please. Thank you. Thank you for being here.
Absolutely. I appreciate it. And let me just say thank you all for your interest in being risk managers in your day-to-day work, because it really is the responsibility of the full clinical team to be diligent about identifying and managing risk. So I very much appreciate your interest in the topic and being able to talk with you. So one little caveat before we get started: our discussion today is going to focus on alert and oriented patients. That's sort of who we're talking about this morning. And I understand that there are some situations where we have some patients, for a variety of different reasons, who are a bit resistant to having somebody stay in the bathroom in arm's length with them. So that's sort of the scenario that we're going to be talking through this morning. So when we think about managing risk for an elective orthopedic patient, does our efforts to manage that risk start in the conversation with the patient in the bathroom?
No.
No. Right. When should it start? Or when can it start, ideally?
The moment they come to the floor. Yeah, the moment they come to the floor.
We're hoping it would start and prepare if they were
For the
elective
elective
patients.
Yeah. So you're all correct. Ideally, it would be amazing if we started setting the expectation with the patient pre-op. So when we have, for example, an orthopedic nurse navigator who's meeting and talking with a patient, or some other nurse educator, that would be a great time to start talking with the patient about how we keep them safe in the post-op setting, and what we do specifically to keep them safe, particularly when they go to the bathroom. So we start that education early, and I think most of us probably know that as adult learners, we need some repetition for things to sort of sink in. So that pre-op conversation should not be the only conversation that we have with the patient. So once they get admitted, anytime you're going in to assess the patient, particularly at the beginning of your shift or other spots throughout, that would be a great opportunity to reinforce with the patient our expectation about using the call bell, and then talking them through, when you have to go to the bathroom, please use the call bell. We'll walk you to the bathroom and stay with you within arm's length, and then we'll assist you back to the bed to keep you safe. How many of you have toddlers or young children in the family that you've worked with that are constantly asking why? It's really helpful when we're educating patients to get to that granular level, because sometimes I think as adults, we tend to be a little resistant when somebody says, okay, this is what we're going to do, without really getting into the why. And I think even something as superficial or generic as saying that we're doing it for your safety might not even be enough, because if there's patients that don't have a clinical background, that they might not really understand what we're saying. So I would suggest that those conversations get to the level of, we are, assisting you and staying with you into the as you go into the bathroom, so that we can prevent you from falling. And you could share that, sometimes post-op patients suddenly feel woozy without warning. Sometimes for our joint patients or even other patients, sometimes their leg buckles without warning. And if we're not in arm's reach, we're not going to be able to keep you from falling, or at least to safely assist you in that fall, to keep you from hitting your head or landing on your hip or the surgical area or things like that. So getting a little bit more detailed, as opposed to just saying it's for your safety, but talking through what that means and what we're trying to prevent. So we've started our education early. We've continued this education through their stay. The documentation, we're getting into that little bit more granular level of explaining the why. The next step is really documenting and documenting well. So anytime a patient has a fall, if there's documentation after the fall that says, oh, before the fall, I told the patient that it was a bad idea to go to the bathroom without me or to not let me stay in the bathroom. But if that documentation is in the chart after the fall, sometimes that's our earliest opportunity to document. And I understand that. I'm not pretending that everything's perfect and we have time to document in real time every time. But to the extent that we can document that education before a fall occurs, it looks a lot better so that it doesn't appear, for example, to be self-serving to document after the injury or after the fall that what our interventions were before. So we're doing frequent education, we're starting pre-op, we're getting to that granular level, we're documenting. So what happens if we go in to take a patient to the bathroom and they say, no, I don't want you to stay in here with me? What's one of the H3W leadership behaviors that we could use in that moment?
Encourage them that it's for their safety, that you are standing there with them so they don't fall. Just
Yeah.
explain to them why you have to be in there.
Right. So we can reinforce the education. What else can we do? We can be curious, right? We can be curious and try to understand what their reality is and try to understand what their resistance is. So for example, if there's, say, an elderly female patient who is being assisted by a male nurse or a male technician, sometimes they just don't feel comfortable having someone of the opposite gender in the bathroom with them for their privacy. So if we use that opportunity to understand the patient's why, then we can see if we have a chance to be able to find a solution that addresses their concerns but meets our needs as well. So in the situation that I gave, the male nurse or male tech can seek assistance from a female colleague to go in and stay with the patient in the bathroom. So using that opportunity to try to understand why the patient is resistant and seeing if we can find a solution to that. So we're doing this education. We offer the solution, hopefully, that meets their needs, but the patient still refuses to have us stay in the bathroom. What do you think about that?
Most time, in my opinion, most time when I try to talk to the patients about, this is for your safety, and the medication that we take is going can cause a lot of stuff. Sometimes they still listen to me, but then I have to literally say, I can't leave. I got 11 grandkids. They need some food. So please. And they're like, okay. All right." That's my little trick that I use. I try to tell, I can, I don't want to lose my job. And I try, some of them say, okay, Donna, I don't want you to lose your job. Good, you can stay. And I'm fine. So everybody have a different. That's a fun one. Yeah, so, everybody have a different. And I say, you got some that literally determine, especially some guys. But I try my best what to do.
Yeah.
Yeah.
And I think I love the approach that you use there to try to use some humor to try to persuade them to allow us to use the interventions that we need to keep them safe. But if they still continue to refuse despite our best efforts there, alert and oriented patients are autonomous, right? I mean, they have the right to make a bad decision. We don't have to agree with it. We can say that we would have done something different in that situation. We can say that we would want our family member to make a different decision. But the bottom line is they're autonomous and they have the right to make bad decisions. So in that particular case, document, document, document. So that is a situation of what I would say informed refusal. So when we document that, there's two parts to an informed refusal. The first is that we inform them. So we have to, of the risk. So we have to document really well that we used yet another opportunity. And by this point, you've been documenting all of your education throughout the course of the patient's hospital stay on all of these different shifts. So we will see in the medical record a trend for educating the patient about the risks. So with the informed refusal, you want to document yet again that you had a conversation with the patient. You explained why you want to stay in the bathroom at arm's length with them, that it's to keep them safe and to prevent them from falling and being injured. And that with that information, the patient is still refusing. So document the informed refusal really, really well. So that's sort of a very high level approach for managing risk in the bathroom and for patients who are high risk for falling, which of course almost all of your patients are.
I think I would always also tell them though, that you're gonna be right outside the door. Please do not get up.
Yeah.
You know, when you're finished, I'm right here, just let me know when you're done. I mean, sometimes they don't listen to that, but
If they refuse to be within our.
Yeah.
Yeah,
Yes.
you can say that. But I would also just add that I don't want to give them false reassurance that that's keeping them safe, because that
Oh, right,
knee's going to
right.
buckle.
Yeah.
right.
And you're going to hear the crash. That's going to be your cue to go into the bathroom door. So I think, yes, you can tell the patient, I'll be right outside the door. Please don't get up. But just be aware that I will not be able to reach you quickly if you
Yeah,
fall, and I won't be able to assist you. So this is not really preventing harm to you.
And we do say, these floors tear flesh and break bones. I won't fall, I won't fall. But really, you won't fall until the fall happens, until you do fall. And listening to what Dawn was saying about, I have 11 grandkids. The other thing I've heard some of you say is like, this is, I'm gonna have to tell your doctor that you're refusing the bed alarm. Or if you fall, then your surgeon needs to hear this. And many of them are in fear of disappointing their surgeon. So it's one of the ditch effort responses that has been used that's rather effective at times, but at the end of the day, you inform them, you document. People do get a choice, to your words, to make bad decisions, but it's an unsafe decision in a public building of healing that floors can tear flesh and break bones, especially what you said too. They can buckle, they're on opioids, the whole gamut of risks. And that's why you're here. Yes.
We have a question up here, Carol.
Sure.
Go ahead, Pat.
Okay, even though some of them insist on having their privacy, I try to ensure that if they are sitting, they sit before I leave the bathroom.
Yeah,
That's good.
And then what? You get up, you tell them not to get up until you're there with them?
yeah.
Most definitely.
Yeah.
So
Thank you.
what I do, I tell her, okay, I gotta make sure you sit before I give you a little bit of time. And I'll, when they sit and everything at the door, I kind of cut the door and I'm like,
Yeah.
make sure, watching to see. And I say, remember now, you promised me, I'll do it. And they sit and do their thing and they're like, okay, Dawn, I'm ready.
There's a
Yeah,
lot of
so
good relationships.
if, like a patient who's refusing alarms, although like they still call for the bathroom, but they don't want, like they call for the bathroom, but they don't want anybody in the bath. They think they're good. They just call to let us escort them to the bathroom. Would that still like document it, but is there anything else that?
So I'm sorry, say that again. If they're refusing the bed alarm,
Already, like. Post-op, no alarm.
So they're in the bathroom because we don't know they're in the bathroom.
Right, yeah.
oh, they refusing the bed alarm and they've made it to the bathroom. Yeah. So that risk prevention starts way earlier than that particular situation. So again, it's having a conversation with the patient to make sure they understand the purpose of the bed alarm, and why we're using that. We talk with them about the risk of them trying to go to the bathroom by themselves, that all of those things that we've talked about, the pain medication that they're on, the knees buckling, that sometimes the dizziness and wooziness can come on, even if they start off feeling good, midway to the path to the bathroom, they start feeling bad, and then there's no one there to help them. And that all of those interventions are being used for the sole purpose of trying to keep them safe and to keep them from falling. So, I mean, if we're educating and continuing to educate, we're explaining the why, we're giving them the rationale, alert-oriented patients still have the right to make a bad decision. Yeah.
That's the
But the-
last ditch effort though.
Yes. The best thing that you can do to protect yourselves is document those conversations as close to real time as you can so that they're in the record before any fall or injury occurs.
I think what we can, in lieu of time, we're starting clinical progression rounds. We can take some of this outside if you have questions. And we can update the recording too. But,
I think what maybe be a little bit helpful to staff is like a sufficient documentation of the refusal of alarms, like what you guys would consider sufficient enough to protect us. And bone and joint would be nice to like show us what you would like from documentation.
For your note of the.
Yeah,
informed
for like our
refusal.
notes for like the refusal of the alarms, extra comments, that would be really helpful if that's possible.
Yeah,
we can-
yeah, absolutely. I mean, it could be something like, patient put on call bell to go to the bathroom, patient walked to, I walked and escorted the patient to the bathroom. I reinforced that I wanted to stay within arm's length of the patient. He or she refused. I explained
Mhm.
the rationale for it. I asked if there was some solution that we could find that would allow a staff member to stay. Patient continued refusing and asked me to step out of the bathroom. Like just documenting the education, the why, and that the patient continued to refuse despite that information.
Can we come up with something like a dot phrase that we
Yeah.
can just put in, so it automatically we can just throw it into our note?
I'm so sorry. I'm
Sorry.
hard of hearing.
You're good. I said, can we come up with like a dot phrase, so like when we're writing our notes, it can just like automatically put it in saying that we've educated on all these things. And yet they're still refusing alarms. That way nothing's skipped.
Julie, do you know what a dot phrase is?
I do.
Okay.
Yeah.
We can talk about,
You can actually create your own dot phrases. I can show you how.
we can do it as a.
Yeah, but I
means
think
to-
it's important to not just put it in, it's important to make sure the education's given
Right.
too, right? So, but I can show you how to make a dot phrase. I can probably make one and share it,
Mhm.
but yeah, but we can do that.
And
Absolutely.
the only sort of thing that I would say just to be mindful when we're using things like templates or dot phrases is that if you're putting it in the patient's chart, make sure that it's true.
Mhm.
So if you're, like she said, if you're documenting and you use the dot phrase and it says that you educated the patient, make sure that you actually did educate the patient on all of that.
Should be in their education care planning, correct? Yeah. Yeah. In addition to that dot phrase.
Good point.
What other questions? Okay.
That's great.
Thank you
Julie,
guys for
thank
having me this morning. I appreciate it.
You guys okay up there?
When they put in the phrase,
Yeah.
and if you have to do the motion, for the motion.
Good, nice to see you. Thanks for making this happen here. It's good for the team. So we've recorded it, we have the appendix.
That's.
Okay.